Hello and welcome everybody. Thank you for attending the webinar. Hopefully we're a little bit more slick this week since we've had practice last week moving through slides and jumping from speaker to speaker. We might just wait another minute or two and let a few more people jump on board. Hi everyone, we'll make a start. So thank you for coming along. I'm really proud and excited to welcome you to this really great session. Partly great because I'm presenting as well today. So we'll just move through our slides. There we go. I'm Renee, I'm a lung cancer nurse at the Royal Hobart Hospital, and I'm presenting these three webinars in conjunction with the Lung Foundation Australia, the Australian Lung Foundation, and also the ANZ LCNF, which is the Australian New Zealand Lung Cancer Nurses Forum. And first of all, I'd like to acknowledge the traditional owners of country throughout Australia and recognise the continuing connection to lands, waters and communities. We pay our respect to Aboriginal and Torres Strait Islander cultures and to elders both past and present. So there's a rundown of what we're going through tonight. And as we did last week, we'll ask people to save their questions till the end, but you can shoot through a question anytime you want in the question and answer panel. It's probably down at the bottom of your screen. It doesn't have to just be questions. If you've had some experience and you've got a comment or something like that to share with us, please feel free and we can have a chat about that right at the end. And also Dr. Rebecca Tay, one of our oncology consultants down here in Hobart, will be telling us all about gene mutations associated with lung cancer. There you go, that's what we look like. And just to let you know, this week we've got participants from all across Australia. We've got WA online this week, so hi WA, and we've got New Zealand again as well. And this is just again breaking down all our different roles from across Australia, so it's really exciting to see so many different roles represented there. And I'd also like to thank AstraZeneca for providing an education grant to allow us to bring you these three webinars. Just to also let you know, the sessions are being recorded, so people can watch them again later on if there's something they missed or if they just couldn't attend tonight and they want to catch up. If you're feeling a bit self-conscious about your questions, just you can click the anonymous button so no one knows who or where you're from. Also, if you do want to send a question in by name, feel free to say where you work if you feel like it, you don't have to. And right at the end, when the webinar is completely finished, the survey will pop up at the end. So we'd love it if you fill that in, because each time you do that, we can improve our next session. So next up, it's me, hello. And I'm going to be talking to you about paraneoplastic syndromes. So you've probably all nursed someone that has had a paraneoplastic syndrome, and there's lots and lots of letters involved. So the sort of overarching thing about this session was, what do all these letters mean? So as you'll see with Rebecca's presentation as well, we like to have acronyms for everything and it can get quite confusing. So first of all, paraneoplastic syndromes. I'm going to talk about what they are, why they happen, how they're classified, and the most common paraneoplastic syndromes that are associated with lung cancer. I'm going to start calling them PNS, another few letters, because saying paraneoplastic syndrome 50 times is going to get rather tedious. And also in conjunction with that, talking about the nursing considerations when you're looking after people with these syndromes. So what about this word paraneoplastic? So it comes from the Greek, and where para means alongside, beyond or around, neo means new, and plastic is like a developing or a formation, a growth. So it's beside a new formation or a cancer. So it's an indirect effect of having a cancer. So it's not, it shows up in other parts of the body. It's not necessarily directly where the cancer is occurring. And it shows up as signs and symptoms either occurring, sorry, I've lost my spot, as a result of organ or tissue damage from the things that the cancer causes the body to do. And quite often at locations remote from the tumour or from the metastases. So we classify them into different body systems, such as endocrine system, neurologic systems, inflammatory systems, rheumatologic systems. And in lung cancer, they tend to happen, they can happen in any of them, but the most common ones are the endocrine, the neurologic and the cutaneous, and particularly with small cell lung cancer. So what happens? So it's kind of hypothesized, so it's not directly proven, but the thinking behind it is that the cancers, either themselves or the metastases or the body's own response into having a cancer present, secretes things like growth factors, antibodies, cytokines, hormones, enzymes and fetal proteins, and that causes a bunch of symptoms in the body. So in all cancers, these syndromes occur in 7 to 15%, but in lung cancer it's about 10%. So what's the treatment for paraneoplastic syndromes? Well, generally with all of them, it's treating the primary tumour or controlling the primary tumour. So we can manage the symptoms, but we tend not to be able to get rid of the symptoms unless we can get rid of the cancer. And sometimes even the symptoms of a PNS can actually be an indication that the lung cancer has either relapsed or it's started to metastasize. So on this screen, there's a whole bunch of different of the syndromes, but I just highlighted in light yellow there the most common ones that we see. So the biggest risk of having a PNS is in the first year of diagnosis, and 9% of all small cell lung cancers have a PNS at time of diagnosis. Now, so if we look at hypercalcemia at the top of the screen over here, and the mechanism for it, that's actually a direct result of the tumour secreting various substances into the body. This biggest risk in the first year of diagnosis probably makes sense because sometimes the PNS can be actually evident before the cancer is discovered. And so it makes sense that it would be there in the first year of diagnosis, especially when the cancer's only just started being treated or not treated yet. So by category, so the ones in green here are the ones I'm going to go into a bit more detail with. So the endocrine system, the neurologic system, the cutaneous or the skin, and other, so sort of unclassified really. Now, some of these, as I said, they can all occur in all cancers, but as you see here with the Lambert-Eaton, the LEMS syndrome, it's rare in all cancers with a total of 1% occurrence, but up to 5% in lung cancer and 3% of small cell lung cancer. I'm going to talk about the paraneoplastic syndromes from the endocrine system now. So these ones are the most common and understood. So they're caused by hormones, steroids or cytokines secreted by the tumour, and such as hypercalcemia of malignancy, SIADH, which is syndrome of inappropriate antidiuretic hormone, and also Cushing's syndrome, and I'm not going to say that whole big long word there. So hypercalcemia occurs in 10 to 40% of all cancers. In lung cancer, it's most often associated with squamous cell, but can be with any of them. The clinical features depend on the severity and rapidity of onset. Most patients will have bone mets, but not definitely all of them. And if it's left untreated, there's a 50% mortality rate from renal failure, cardiac arrest or coma. And also if the cancer goes untreated and the hypercalcemia goes untreated, then median survival time is 3 months. So symptoms of hypercalcemia include changes in mental status, confusion, nausea and vomiting, anorexia, constipation, fatigue, polyuria, thirst, dehydration, and back pain and muscle spasms. And it's quite easy to find it. You just need to do a blood test. So what do we do about it? Rehydration, bisphosphonates, which can take a few days for the plasma calcium to respond. Long-term control is the control of the underlying cancer. Stopping other drugs that may contribute to high calcium levels, such as calcium supplements. And for nursing care, communication with the patient and family, explaining what's going on, explaining about high calcium levels and how they affect people. Just thinking about patients that might be a bit confused, they might be acting abnormally, and their patient's family might be really concerned that maybe they have brain metastases or something like that. Reassure that our goal is to return the patient to normal calcium levels, and therefore they'll return to their normal function. Encourage mouth care, check skin integrity, and consider antiemetics, laxatives and analgesia and so on to treat those symptoms until the calcium levels are back to normal. Okay, now we're going to move on to SIADH. Hypercalcemia is one of the ones I've seen the most often, I'd say, followed probably by this one. So syndrome of inappropriate antidiuretic hormone. So it's a disorder of impaired water excretion caused by the inability to suppress the secretion of antidiuretic hormone, or ADH. So if water intake exceeds the reduced urine output, the ensuing water retention leads to the development of hyponatremia. It most commonly occurs with cancer, but can be present in other disease processes as well, and even some drugs such as diuretics or vincristine, cyclophosphamide. So in small cell lung cancer is 75% of the reason why this syndrome might develop, and up to 40% of small cell lung cancer cases. It's also sometimes referred to as water intoxication. I've never actually heard it called that one. So what are the symptoms? Tiredness, lethargy, nausea first, low urine output, weight gain, headache, confusion and delirium, muscle cramps, and eventually can lead to seizures, comas and death. There's some conditions that can mimic SIADH, such as cardiac, renal and thyroid disorders, so they need to be ruled out as well. Treatment for this is chemotherapy and or treatment of the tumour, fluid restriction, medication to block the ADH, diuretics, and again, like the other syndromes, the sign of recurrence may be the return of SIADH. So nursing considerations: explain the blood results to the patient and the family, explain why fluid restriction is required, keep a fluid balance chart, offer mouth care. You can imagine this person's probably feeling pretty dry. Check skin, offer moisturiser to protect the skin, daily weighs, assess patient's mental state, assess for cramps and nausea and seizures, and also balancing the quality of life versus treatment if the patient is near end of life. Sometimes it might actually, like talking about fluid restriction, if someone's in the last few days of their life, they're probably restricting them drinking and enjoying something is probably just not worth it. Probably just letting things happen and making sure they can spend quality time with their family is more important. Fluid restriction is really horrible. I don't know if anyone has ever had to do it, or even if you just have to fast for a minor procedure or something. You know how dry your mouth gets. So I think most patients I know find it really hard to stick to the limit. So encourage sips rather than taking big drinks. Ice chips can be useful. Explain that it's temporary, and once we get their sodium back to normal, they can go back to drinking normal as well. It doesn't have to be for a long time, and just encourage them to try and stick to the plan. Next, we're going to talk about finger clubbing, as part of HPOA, which is hypertrophic pulmonary osteoarthropathy. So I also see this a lot in my patients. It's not definitely always in lung cancer, but 90% of the time, it's usually a paraneoplastic syndrome. You've probably all noticed this, I'd say. Early stages are subtle. It's not painful at all. Imaging is not useful to diagnosis, and it's a build up of bone in the, I'm running out of time, build up a bone in the ends of the long bones, and sometimes an effusion at the joints, particularly large joints. So this is HPO when it's occurring like in ankles and knees and things, and can be mistaken for arthritis. So that picture there is showing you the simple test to see if someone's got clubbing. So you can see this angle here in the normal fingers, and it disappears there. And every now and then I like to just check my angles for some reason, because it's a very simple test. And there's a picture of what clubbing really looks like. So HPOA in the long bones, we can use a bone scan to diagnose this, or an X-ray, and it shows up as symmetrical pain, which is important to remember. It's pain on both sides, so both ankles, both wrists. And treatment again is control of the cancer. If the cancer is resectable, then the symptoms resolve, and also your non-steroidals and steroids and analgesia to treat the pain until you get it under control. Cachexia. Now, the reason I've put cachexia on here is because this is something I really struggle with helping patients and their families manage. So it's a systematic inflammation, which 2/3 of people with any advanced cancer can show up. It's a marked rapid weight loss, and it's caused because cytokines, tumour necrosis factor and interleukins are present and associated with increasing the patient's metabolic rate and energy expenditure. So symptoms include more than a 5% loss of weight, muscle wasting, nausea and vomiting, early satiety, feeling full quickly, anorexia, diarrhea, malabsorption, anemia, altered sense of taste and smell, and bowel obstruction. So what do we do for cachexia? It's really difficult, and I think everyone finds it really hard. So we can offer nutritional supplements, steroids, progesterone to increase appetite, anti-inflammatories, antiemetics, skin and pressure care, involving our multidisciplinary team, avoid routine weighing, encourage the caregivers to focus on quality activities, not feeding and weight loss. This is where sometimes I feel like the family become the food police, and they're trying so hard to get their loved one to eat something because they know that if you don't eat, you're going to die. And looking at their loved one so skinny distresses them greatly. And the one thing they can actually normally do is cook a nice meal for their loved one. We need to help with bowels, and also the other thing that happens is when people lose weight from all over, their dentures might become ill-fitting and their clothing starts to hang off them. So try, if it's possible, to get those things modified just so that it's not uncomfortable. Counterintuitively, it might seem, some aerobic exercise actually helps reduce the systemic inflammation and can actually help people feel a bit better. And we avoid aggressive interventions such as nasogastric tubes or TPN feeding, anything like that. And it's really important to use our multidisciplinary team here, so OTs, physios, dietitians, just to see what we can do to help make this more comfortable for people. So I'm nearly finished. So in general, with paraneoplastic syndromes, it's really good to have a thorough history of your patient, establishing a positive rapport with patients. They're rare and diagnosis is difficult, and as you can see from the symptoms we've already talked about, those symptoms could be lots of different things. Sometimes it's probably more of a going through a list and sort of ruling things out. And as cancer nurses, we're in a really unique position in that we get to really know our patients. Our patients return to us all the time. We see them a lot. So by building that rapport, they feel comfortable reporting odd signs or symptoms to us, and we can start the process of looking into things. Improving quality of life for patients with referrals to our other team members, PAL Care, social work, other allied health. Support when treatments are no longer working, and early detection and quick and appropriate management brings better outcomes for patients. And there's my references. And now I'm very happy to pass on to Dr. Rebecca Tay, staff specialist here at the Royal Hobart Hospital, and she's going to talk to you about mutations associated with lung cancer.
Good evening, everyone. We just did a quick chair change, really. Thank you so much for inviting me to speak today. So my presentation is centred around personalised therapy in advanced non-small cell lung cancer. So for the next 20 minutes, we'll go through particular gene mutations associated with non-small cell lung cancer, or what we also refer to as molecular subsets. We'll talk about some case studies of real patients, where we'll discuss how patients may typically present with these gene mutations, how we work them up in a diagnostic sense, treatment options and management of treatment toxicities. And we'll also at the end briefly talk about some emerging targets. So personalised therapy in advanced non-small cell lung cancer has come a long way, particularly in the last 5 to 10 years. Lung cancer, unfortunately, remains the most common cause of cancer mortality in Australia. We have an estimated more than 8,600 deaths this year alone, with nearly half of the patients presenting with advanced disease. Fortunately, lung cancer survival is improving, as the 5-year survival has increased from 9.5% to 19%, accounting for all stages. And this is largely due to some patients presenting at an earlier stage. We do have improvements in diagnostic staging, particularly with the introduction of PET scans. And importantly, we also have new therapies providing new hope for people, including immune checkpoint inhibitors, a bit outside of the scope of today's talk, but also the move towards personalised, or what we also call precision medicine, and the use of targeted therapy. The whole concept of matching a patient's condition and their comorbidities to the right treatment, and not just a one-size-fits-all approach. So we have traditionally treated lung cancer based on the histology alone. So we divided patients up with lung cancer into small cell lung cancer, accounting for about 15% of cases, and non-small cell lung cancer, where the subtypes being adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Previously, treatment for advanced non-small cell lung cancer, so stage 4 lung cancer, was chemotherapy alone up until very recently. The median overall survival for someone with stage 4 lung cancer was about 8 to 12 months, and the 1-year survival rate was only 33%. And this pivotal study about 20 years ago, which seems like a long time ago, they compared different types of chemotherapy partners with cisplatin or carboplatin, and they were all basically very similar in terms of survival outcomes. A few years later, we've marginally improved some survival, tailoring the chemotherapy based on the histology. So patients with adenocarcinomas versus squamous cell carcinomas had a different type of chemotherapy, where we found that the combination of cisplatin and pemetrexed for patients with non-squamous histology resulted in a very marginal improved overall survival of really only about 1 month. And pemetrexed was only available on the PBS last year. The real shift and change in personalised medicine for lung cancer came with the discovery of what we term oncogenic driver mutations. So in a normal cell, all the genetic material to make that cell divide and grow and live is housed in the nucleus, or the brain centre of the cell. In that nucleus is DNA, and encoded in the DNA is genes. And in a normal cell, the growth turns on and off because the genes are properly regulated. In a cancer cell, the reason why some cancers grow and spread is that they have oncogenes which accelerate their growth and rapid division in a very uncontrolled fashion. So in lung cancer, the concept of oncogenic driver mutations came about with the discovery that certain genes, when they were present in the cancer cell, transformed it from a normal cell to a cancerous cell. So I like to think of it as a sort of switch approach. In a normal cell, the growth and spread is turned on and off in a very controlled fashion, like turning on and off a light switch. In a cell with or a cancer with an oncogenic driver mutation, it is as if the light switch is turned on the entire time with no ability to turn it off. And that mutation causes uncontrolled growth and spread because the signal telling the cell to grow is always turned on. So we've gone from a shift as treating advanced non-small cell lung cancer as one disease, knowing that they could either have adenocarcinoma or squamous cell carcinoma, and we slightly tapered our chemotherapy based on that, to the discovery of knowing that actually non-small cell lung cancer is a lot more complex, and there are certain genes in some patients which cause rapid growth and division and can be treated in a very different way. So the most common of these genes that you may have heard of include the EGFR gene, the ALK gene, and the ROS1 gene. And identifying these genes in certain patients is really important because it predicts their response to certain treatments, what we would call mutation-directed therapy. So instead of using chemotherapy or immunotherapy to treat every single one of these patients, we can reduce the toxicity and be more precise in how we treat these patients because we can use certain tablets to turn off these mutations. Another really important thing that often comes up when we diagnose someone with a gene-mutated lung cancer is it's important to tell the patient that the abnormal gene is within the cancer cell. It's not within any other normal cell in their body. So it's not something that we technically say it's genetic or can be passed on in their family. In terms of testing for driver mutations, they tend to be more prevalent in patients with adenocarcinoma histology, those that are younger in age, and those with a never or light smoking history. An important thing to remember is these driver mutations tend to be mutually exclusive. So what we mean by that is in someone who we identify an EGFR mutation, they won't have an ALK or a ROS1 or another type of mutation. It's either one or the other or no driver mutations at all. So even though these mutations tend to be more common in those with adenocarcinoma who are younger or who have a very light smoking history, they can still be found in patients who don't fit this typical picture. So our guidelines here in Australia advise testing for these gene mutations in all patients with stage 4 or advanced, non-squamous or not otherwise specified histology. As a baseline, we would test for EGFR, ALK and ROS1. And the reason for that in Australia is because we have funded therapies. There are different broader panels and it may differ from centre to centre, that include other types of gene mutations, including KRAS, BRAF, HER2, what we call NTRK or MET. But as we don't have funded therapies for some of these mutations, it's not a standard approach to test for these in every single patient. In general, molecular testing or testing for these gene mutations is not recommended in patients who have a squamous cell carcinoma, although we do often make exceptions for those who might fit a different picture, such as those with a never or light smoking history, or those who are quite young in age and develop an advanced lung cancer. So the most common gene mutation, and the one that was first discovered, is a mutation in the EGFR or epidermal growth factor receptor. So EGFR is a protein that sits on the surface of many cells. And when this protein is turned on, it results in cell growth. In non-small cell lung cancer, there can be an abnormality in the EGFR gene in the cancer cell. So when we have a mutation which is detected, it means that the lung cancer grows and divides in an uncontrolled way because that switch is constantly turned on. EGFR mutations occur in about 15% of patients in a Caucasian population, but really interestingly, the incidence increases to up to 60% for those of East Asian ethnicity. In patients who have an EGFR mutation, we actually have a number of agents available to treat these type of cancers. So these agents are called tyrosine kinase inhibitors, or what we would typically call oral agents or oral targeted agents. The way they work, I'm not sure if this pointer works.
Yeah.
Oh, great. Is that the normal EGFR protein sits on the surface of the cancer cell. We have this, with the top that sticks outside the cell is called the ligand binding domain, and the part that sticks out at the bottom of the cell is called the tyrosine kinase domain. So in a patient with an EGFR mutation, this whole protein is abnormal. It means that it's constantly turned on, producing a signal for that cancer cell to grow and divide rapidly. When a patient has an EGFR mutation, we would typically prescribe an EGFR TKI or targeted agent. And the way this agent works is it's a small molecule which goes into the cell and binds to the tyrosine kinase domain, essentially turning off the growth of that cell or turning that off switch. We have a number of agents available, and the one in bold called osimertinib or Tagrisso has been just subsidised on the PBS a couple of months ago. So I think I have 10 minutes. The most amazing thing with these targeted drugs is it causes a rapid response. So this is a patient who had EGFR mutant lung cancer, and you can see cancer throughout the entire lung fields. And this is a chest X-ray taken 3 days later. The responses to these TKI agents are amazing and can be very rapid. These agents only work in patients with a mutation, and based on a pivotal study, we've shown that it doesn't work in anyone who doesn't have the EGFR mutation. This is a case study of one of my patients who was a 46-year-old male, never smoker, of Asian ethnicity. He presented with back pain, dry cough, and night sweats. He was referred to the respiratory unit following an abnormal chest X-ray. He has a past history of TB and no family history of cancer. They found a right upper lobe mass, enlarged lymph nodes, multiple pleural and bone metastases. This was confirmed on PET scan, and he had no tumours in his brain on MRI. A VATS pleural biopsy confirmed features consistent with adenocarcinoma. So we detected in this patient an exon 21 mutation, no mutations in ALK and ROS as expected, as they're mutually exclusive. And based on finding this mutation, we started anti-EGFR therapy, a TKI therapy called afatinib. He commenced afatinib, and 8 weeks later, he developed this very nasty rash with some superimposed infections. He was admitted for IV antibiotics, and we dose reduced his afatinib. So I'm just trying to demonstrate that the most common side effect of these agents is a rash. We grade it based on the extent of the rash and also some of the associated features like superimposed infection. And this is usually treated with pausing the TKI, treating with antibiotics if appropriate, sometimes with steroids, and then often considering a dose reduction if necessary. So you can go through these slides later on, and I've just provided a management algorithm for common skin toxicities for EGFR mutations. I might just skip through to talk about one other main common mutation called the ALK mutation, or anaplastic lymphoma kinase. So this is actually what we call a gene rearrangement. Instead of that abnormal protein on the cell, within the DNA of the cell, we have genes which are flipped. And these rearrangements in ALK are present in 3 to 5% on non-small cell lung cancers. They most frequently occur in patients who are non-smokers and are younger in age. We have quite a number of ALK inhibitors or ALK TKIs which are available on the PBS. The ones I've highlighted in bold are the ones with probably the best efficacy data and are available. When we've compared a next generation ALK TKI called alectinib to the first generation ALK TKI called crizotinib, we can see that alectinib has a much better progression-free survival, meaning that patients are living longer on the drug without their cancer progressing, and with impressive response rates, with around 83% of patients on this drug showing visible shrinkage of their tumour. We know patients with crizotinib live approximately have a median overall survival of around 4 years. We don't have that data yet for alectinib because it's just been really impressive. And we hope that in the next 10 years to come, we'll have we're able to better tell our patients an expected prognosis on this medication. So this is a patient of mine who's 58. She's a lifelong never smoker. She's Caucasian in background, and she's got no significant past medical history or family history. She's extremely fit and well. She presented with a cough, hoarse voice, and loss of weight. A PET and CT showed a right lower lobe lung primary, nodal metastases, multiple bone metastases, and also a pericardial effusion. So quite a lot of fluid was actually present around her heart, causing near tamponade. This is a shot of her PET scan where we can see the large tumour, some lymph nodes involved. She had a bronchoscopy, and quite unexpectedly it showed a squamous cell carcinoma, a cancer which is most commonly associated with patients with a heavy smoking history. Because this patient, although she had a squamous cell carcinoma, she was young and had never smoking history. She didn't fit the typical phenotype of a non-driver mutated non-small cell lung cancer. So we went and did molecular testing, and we actually found an ALK mutation. So we tested in two ways. One is what we call immunohistochemistry, where what we call a positive, this brown staining, shows that the ALK rearrangement is present. And then we confirm it with another test called FISH, where they use probes to highlight the ALK gene. And because we know that in an ALK mutated cancer, the genes are rearranged. So instead of seeing the kind of traffic light colours lined up in a row, we see these split colours, confirming that the gene has been rearranged in an abnormal fashion. So we commenced her on an ALK tyrosine kinase inhibitor or targeted agent called alectinib at a dose of 600 milligrams twice daily, which is the standard approach based on the ALEX study. And I'm pleased to report that she's had a phenomenal response to the treatment. We can see a near disappearance of her tumour. She's exceptionally well, and her voice has recovered back to nearly normal. So it's always worthwhile when the picture doesn't quite fit a young patient with a squamous cell carcinoma, potentially checking for these abnormal gene mutations, as otherwise she would have been started on standard chemotherapy or chemoimmunotherapy and not had the chance to potentially respond for a very long time to a targeted agent, and she's avoided the toxicities of chemotherapy. So there are a few other genes called ROS1, NTRK, and BRAF with known targeted therapies. They are currently not available on our PBS, so we often, if we detect these mutations, often see if a patient is eligible for a clinical study. One of the most exciting targets or gene mutations is the KRAS mutation. It's known as the Kirsten-Ratt sarcoma virus. Please don't ask me why. It's actually present in up to 25% of lung adenocarcinomas. It was previously known as the undruggable target. There were no agents that they could find which would turn off the KRAS mutation. And finding a drug which targets KRAS would potentially be extremely significant, given that 1 in 4 patients may have this mutation. There's some really exciting data coming through of a first-in-class KRAS inhibitor, so a small molecule or oral agent which turns off the KRAS mutation. It is still very early days, but in patients who've been heavily pretreated with previous chemo and immunotherapy, up to 1/3 of patients had tumour shrinkage and 88% of patients had at least stable disease. And patients were living at least 6 months on this new agent called sotorasib. So further trials are in progress. So I definitely think it will be a watch this space within the next few years. So just in summary, in our last 1 minute, I hope I've been able to briefly talk about that driver mutated non-small cell lung cancer is a very distinct disease with a differing incidence, natural history and treatment options compared to non-driver mutated lung cancer. In these patients where we detect an abnormal mutation, an oral targeted agent would be the standard first-line treatment, and the selection of agents continues to evolve. I think it's really important to involve the wider team, especially in complex cases. Firstly, for identifying these genes and identifying patients for these treatments and managing their toxicity. To talk about when something doesn't quite fit, like in the second case we've presented, and also reassuring patients that a diagnosis of stage 4 lung cancer can be devastating for anybody. And hopefully, as we evolve our treatment algorithms, there's new hope for patients with new treatments and new targets available. Thank you.
Great, Rebecca, thank you so much. That was really interesting, and I actually picked up a few things I wasn't very clear on myself. That was great. If we can both get into the,
We both fit?
I'm not a cameraman, but that looks pretty good to me. So we've already got a few questions come in, but please feel free to keep sending more. I've gone too soon, there we go. Stick on that screen. So one of the first questions we've had through is, can patients develop cachexia even when disease is stable? And I have to say, I actually don't know the answer to that. I don't know if Rebecca has any clearer ideas on this.
I believe they can, because we treat cancer cachexia as a general symptom of a patient's cancer as well. So much like they could, patients manifest fatigue or breathlessness even when their disease is radiologically stable. We treat this as part of their symptoms of their overall malignancy. And the best treatment, yes, for it is active treatment, but I think the supportive measures that you discussed, Renee, are exceptionally important in this.
It's very distressing.
And a very difficult symptom to treat as well.
Yeah. Okay, we'll move on to the next question. Can you please explain what wild type means?
Yeah, absolutely. So it's really confusing. So when we talk about genes, we actually inherit two, one from our mother and one from our father. So when something is normal in its normal form, we actually call it wild type. When something's abnormal or mutated, we call it mutated. So in, say, the EGFR gene, if it's abnormal, we call it EGFR mutated. If we don't detect the EGFR mutation when tested, we refer to that patient as having EGFR wild type. So that's what you'll commonly see.
Hope that clears that one up. And another one from Fran. Hi, Fran. Can you please explain the deletions on some of the mutations? Example, the exon 19 deletion.
Sure. So this will particularly relate to the EGFR mutation. So EGFR is actually a whole a gene where, when you break it down, it's a DNA sequence which codes for the protein. So what I mean by that is, when the DNA is read by the cell, then by some magical way, they develop a protein, and it's that protein which sits on the surface of the cell. So a mutation in EGFR isn't actually just of the whole gene itself, but it happens at particular places in the gene. So the two most common places where we've found the EGFR mutation is at exon 19, and they call it an exon 19 deletion because some of those amino acids are deleted. And there's also called an exon 21 insertion because the abnormality or that mutation happens at exon 21 in the EGFR gene, where they've inserted some, or by they meaning the oncogene, is an abnormal insertion of extra DNA, which causes the switching on of the mutation. So exon 19 deletion and exon 21 insertion are what we typically used to call the sensitizing mutations. So with first and second generation EGFR oral therapies, gefitinib, erlotinib, afatinib, they targeted 19 and 21 and not some of the others at, say, 18 or 20. Some of the newer agents are broader and they target more than the traditional 19 and 21. I hope that makes sense, and please ask another question if I haven't clarified it.
Thank you very much. There's another question come through about, if I was a new nurse to lung cancer nursing, where would you recommend I find more information on paraneoplastic syndromes, and in particular nursing support of patients with PNS? Really good question. I'm trying to think of the name of that group. I think it's MASC, M-A-S-C, which has great resources for everyone, including nurses, on lots of side effects, lots of symptoms of cancer, not just PNSs, but and how to manage them. If anyone in the audience has any more to add to that, please send it through and I can read it out. I've just got another question here. Sorry, that wasn't very succinct, but see what other people have to say. How do you help manage the anxiety surrounding scan times and this possibility of the cancer having stopped respond to one of these oral drugs?
Particularly in the oral setting? Yeah. So I think managing expectations is such an important and difficult part of our role as oncologists and as cancer nurses, I imagine, because sometimes I've seen and I've heard it expressed to patients that, oh, we found a gene mutation, that's really great. And I think firstly acknowledging what they're going through is often, you know, some of these patients might not fit that typical phenotype of what our usual expectation of a lung cancer patient should look like. So I think it does come as a big shock to them. So tapering the expectations right at the start is really important. So I think reassuring them that we have very good treatment. We know from a lot of the studies the general or average expected time someone might be on these agents. I usually do say to my patients who we discover a gene mutation in, it's like, you know, it's good, it's given us an extra treatment option or options for clinical trials. We know from the data that at some, often cancers or your cancer will respond to this treatment, but at some stage it will become resistant and we might need to consider other treatments down the track, such as chemo or immunotherapy. And knowing the data, so for instance, with osimertinib, the average amount of time may be around 18 months before a patient may start progressing. So knowing the average is sometimes helpful for patients. I think in terms of managing scan anxiety, I often say, and people sometimes don't want to have their scans because it's a really terrible time for them to wait. I think firstly, only doing a scan when you need it to help manage your patient, and often we need to. So I typically scan every 6 to 12 weeks. I try and book the scan a couple of days before their clinic appointment, so they're not waiting 1 to 2 weeks. And I know that's really hard at every centre to do, but often we can plan an appointment in advance and we can specify if the scan is booked enough in advance to have it 1 or 2 days for enough time to have the scan, to have the results, but to limit that time waiting for a result.
Yeah, that's really good. I think it's that upfront when you first meet a patient of being open and honest about expected times. I mean, a lot of patients don't want to know prognosis and things like that, but you can introduce it in a way that says, okay, we've got this drug and it's gonna most likely work well for you, but at some point in the future it will stop working, and just preparing people for when that time comes. That's really, really good. We have another question here about, why do you avoid nasogastric tube insertion in cachexia? Are there circumstances when you would use it? I think we don't use it because it's an invasive kind of process, and feeding the patient probably actually isn't going to solve the cachexic problem. It's another insult to their body image and how they see themselves, and I can't think of any other reasons really, but I think it's probably more futile than it's probably going to do more harm than good for in general overall.
I think there are certain risks with nasogastric tubes as well, particularly in someone who has lost a significant amount of weight, perhaps with end-stage lung cancer. There is a risk that the NG shifts and you could, get an aspiration pneumonia. We have seen the odd case of NG tubes causing esophageal perforation. So it's not always a benign procedure. But also, I often explain to patients, particularly at the end or terminal stages of their life, that I think eating and drinking can be a very, primal reflex as well. And, part of the reduced appetite and reduced eating, does signify that the cancer is very advanced, and often additional nutrition is not necessarily life prolonging.
Yeah. We've just had some more information come through about where you can find out more information about paraneoplastic syndromes and how to manage them. So EviQ, of course, how could I forget EviQ? I use it every day, has lots of information on that. They even have an online learning module about SIADH. And looking through, yeah, the learning model on EviQ. So that's just EviQ. If anyone's not familiar with it, just Google it, you'll find it. And it's got lots and lots of information about all the different treatment regimes. In fact, that's what we use to give handouts to our patients when they're, so it's got patient information, it's got clinical information, side effect information. Alrighty, have you got any other questions there?
No, I was going to ask you how you diagnose SIADH, because I know there's sometimes special blood tests, but often we do it clinically, like I guess the constellation of someone having maybe extensive stage small cell lung cancer with hyponatremia.
Yeah.
Often, and it signifies to us the best treatment for it is treating the cancer.
Yeah, so. Yeah. I find sometimes the patients, when they go on their TKIs or something, they call it chemo tablets. They still call it chemo even with our best information. Do you just let them run with that, or do you try and correct them, or do you try
No, that's a good. I try not to shove it down, but I try to be very clear that it's not chemotherapy.
Yeah.
I do think it's important not to, I think, breed a fear of chemotherapy, because I think we have to acknowledge that, you know, others may have had a bad experience or have a family member have a bad experience, not just with chemo, but any other treatment. But the main reason is because actually we find that sometimes other health professionals may not have a very clear understanding of oncology treatments.
Yeah.
And what I find is, say somebody comes through the emergency department and they tell them they're on lung cancer targeted treatment and it's labelled chemo treatment, and they suddenly find themselves in the back of the emergency department and everyone having purple gloves on and masks and everyone doesn't want to see and I think just re-education and engaging our other colleagues is really important. And also, you know, it's good for patients psychologically. So it's like, oh, I have this other treatment option and it's not chemotherapy.
Yeah.
I think that's a positive.
Yeah. I think it's really good too that you can say we still have chemo up our sleeve as well. There's still another line of treatment if and when this one doesn't go so well. I find with the TKI inhibitors and stuff, there's a whole range of weird and wonderful other side effects that you see further on, you know, months and months into treatment rather than initially when patients first go on them. Things like their eyelashes grow really long, and they have to get them trimmed, and we recommend they go to like an optometrist or even a beautician to get their eyelashes trimmed instead of trying to do it themselves. And also it changes the texture of their hair will change texture, it becomes wiry and stiff, and I guess it's managing these physical changes with patients. It can really change the way they see themselves, their body image, how they feel going out socially, especially with the rashes that Rebecca was talking about. So a grade 1 rash, while we wouldn't particularly change anything about their treatment, and we can recommend skincare techniques and maybe some steroid cream, things like that, and they can go on the oral antibiotics to help with that. It still may stop people from feeling able to go out, still go to restaurants with their friends or go to the supermarket. So there's a lot of work that I do with patients around that and how to manage their skin reactions. And we actually have Look Good Feel Better here in our hospital that's run I'm not sure how often, maybe every 8 weeks. I'm not sure if you guys out there have access to Feel Good Look Better sessions in your places of work. If you want to let me know, I find them really useful. Patients seem to really love them. For those of you that don't know what Feel Good Look Better is, it's a charity event where the people get lots of skincare and lots of makeup and products and so on donated, and the people that come in and run them are actual trained beauticians and hairdressers and things like that. So it's a really good self-care kind of thing that patients can do for themselves.
Yeah, it's a really positive experience, I think.
Yeah.
I think because TKIs have changed the trajectory of patients' prognosis and the natural history of their lung cancer, it's important not to dismiss other medical problems as well.
Yeah.
So the ALK TKIs can cause a lot of metabolic derangements like high lipids. So that's something that we actually check and actively treat.
Yeah, exactly right. Okay, we might just move on now. So, hang on. Oh, I'm too click happy.
It's like me.
There we go. So just a reminder to please complete your online evaluation survey. The survey will pop up at the end. It's pretty quick to complete. Next week, we're doing professional perspectives. So what's next for me as a nurse? The path of an accidental academic nurse, clinical practice and research, and also nurse-led research, what, why and how. I'd just like to take the opportunity to thank everyone that's helped put all this together. So thank you, Rebecca, for that talk. It was really excellent, really lots of great information, and we've had a few people even comment already. Thank you, and great information. Thank you, Vanessa, in the background up there in Queensland. Thank you, Paula at Med Collective, who I've learned today is in Sydney, not Melbourne. Kelsey at the Lung Foundation Australia, and also AstraZeneca for their education grant.